There's a diverse range of patients that we implant for CRT. The best group are obviously those who have a broad QRS more than 150 milliseconds, but there's this intermediate range between about 130 and 150 milliseconds where there's a bit of variability in response, and that's mainly due to areas of scar where the leads are being placed, so we can improve it by avoiding placing the leads in scar regions, but also identifying sites of late activation and late contraction. And ideally we want to be confident that when we pace that area, the tissue is actually going to be synchronized with the rest of the ventricle, and that's quite a challenge because of the imaging technologies that we're using. There are some difficulties with identifying those sites optimally. Well, the main obstacles are the technology that we have available and also the variability in the patient. So physically, if there's scar tissue, we're trying to pace around it. We may be able to get there, for example, with multi-point pacing, but where the leads are actually being positioned may mean that you're pacing an area where the tissue still can't contract very well, even if you actually pace it. So we're starting to look at other technologies, for example, endocardial pacing, where we can get very good hemodynamic responses for the patients. And there are some newer technologies with leadless pacing which are evolving, we can apply. We have to be very careful about their safety and efficacy going forward. And selecting which patients are suitable for endocardial CRT is going to still be quite a challenge because we have a very good, reliable epicardial approach at the moment. So it's identifying the optimal group that are going to benefit for that. So there are two main types of computer models that we use. One is predicting electrical activity and the electrical response to CRT, and the other is the mechanical response. Now those models are coming together to give us the electromechanical response. So essentially we can predict what the hemodynamic response is going to be by pacing different regions of the heart, and this is very, very powerful, particularly in patients who've got scar in the myocardium. So we can say, well, if there's a scar in this region and we pace just outside, can I predict a better hemodynamic response in that patient, putting a lead here versus there. And that then goes back to this issue of endocardial versus multi-point pacing, or putting more than one lead in the epicardium, because essentially we can say, well, this patient particularly needs two leads in two areas, while this patient would be better off with endocardial pacing. So we can actually prescribe the right pacing technology for the patient, individualized and personalized based on the modeling. And I think we're very close to that with the technology that we have.